I think we heard this, and I think you heard my financial disclosures, and I just started with the patient. I said as clinician we always learn from our patients, and I would like to introduce you to this 12-year-old boy who had thin spurs, these disease flares with fever, rash, headache, conjunctivitis, arthralgia, myalgia, and severe arthritis. The disease flares were always associated with elevated inflammatory markers, and this was the reason why he was more than 14 times hospitalized in different clinics without a diagnosis. So the mom gave up her job. She really took care of this boy. They had major crises in their marriage, problems with the siblings, and she was traveling through the entire country searching for competent care. And when we saw him for the first time at the age of 12, he already had signs of damage like hearing loss, cognitive delay, growth delay, and skeletal deformities. So our clinical diagnosis of CAPS could be confirmed by the molecular genetic testing of a pathogenetic NLRP3 mutation. So we started him right away on iron-1 blockade, next one, and you can see the treatment really worked. The parents were telling us that 3 days after the therapy it was a different child. He had none of the described symptoms like fever, headache, conjunctivitis, and so on. When we saw him 4 months later, we took the picture, and it's definitely a different boy. He gained weight and height. He was much happier, more open, more self-confident, and even the school performance increased. He asked me, would you mind to give me some of your nice slides, because I would like to give a talk now in the school in my class and talk about my disease. Next one. However, in spite of the really great success we had by controlling the inflammation, there were still concerns which were raised by the parents. First of all, they had a long journey until they finally had the diagnosis. They were not taken seriously by many of the health professions, many of the doctors, and they had a hard time now really trusting patients. Now they're facing the fact we have a child who already has organ damage, like the cognitive delay, and they realize even with this great treatment, it means we have to see a lot of doctors for the monitoring. And then there are the future concerns, like what does it mean living with a handicapped child? How will be his school performance? Will he improve? Will he be able to find a job or even have own children? So we realized there are unmet needs even if we are able to control the inflammation. And talking with the patients and their families, we identified really some special burdens which were not only seen in this family. One of these burdens is the lack of knowledge in the healthcare system. And I think many of you as well had the same experience. Most of the negative experience they had to explain and no one really believed. And in some families and patients, it really came to a traumatization. These are quotes from the parents, one back. Like they heard from their doctor, every child has fever from time to time, just relax, everything will be fine. Or don't be afraid, your child will be in good health soon. We know it, I'm a pediatrician. Next one. Another burden is the invisibility of the disease in many of our patients. So the environment permanently misjudge their feelings, so the patients, they feel a discrepancy between their own feeling and the feedback. They have self-doubt and some of them really develop depression. For example, they say, don't be so lazy, you are not really sick, you can do that. Next one. Next one. Another specific burden is the disease impact on their everyday life. Even with treatment, we found out that many of our patients are still suffering from fatigue, really the severe fatigue, which gives them a hard time in school and also has an impact on their work performance. And instead of the understanding from the teacher about the disease, they often get negative feedback, like sentences they had to hear, you should sleep more instead of playing games during the night, or perhaps you should come more to school and then you would give us a better performance. Next one. And this is just one child I will never forget. At the age of 4, he told me, "I'm always tired and exhausted. I cannot keep up with my friends. No one can see that I'm ill. And the worst part was that no one believed me. I do not like to live like this anymore," at the age of 4. And this was the reason why we said we really would like, next one please, we really would like to get more knowledge about it. And this is a German paper where they found out that the risk for children and adolescents with chronic disease to develop a mental disorder is 5 times higher than for healthy peers. Reasons they identified were that several family members may be affected, the burden on the parents, the fears of loss, the limited quality of life, less time for the family, and also the socio-economic burden and the reduced social contacts. Next one. So this was important for us, and we just wanted to see how it is in patients with autoinflammatory disease. So we conducted a study with the aims to identify the spectrum of unmet needs, to define the key unmet needs, and then finally to develop interventions. Next one. So it was studied with different methods. First of all, we did expert consulting, we had a literature review, we had focus groups with patients and family members, and then we had several questionnaires. Next one. Altogether, more than 80 participants were included. Almost 50 were patients of all age, but also healthy family members. Most of them had a diagnosis of FMF or CAPS. And then we had 10 focus group patients, children, adolescents, adults, and also family members. And more than 90% really completed the questionnaire. Next one. And these are just a few of the results. As you can see here, the key domain of unmet needs was rated most for the healthcare system, and the next one was for the school. Next one. Looking into the details, we really were shocked to see that many of the children and adolescents told us, at least 75%, that their teacher had no understanding for the disease or for the circumstances, and almost 90% reported some experience of mobbing or bullying. So the psychosocial burden of patients with autoinflammatory disease can be grouped in 4 main groups. First is the lack of understanding, mainly from the healthcare system, but also from friends in the home environment. Then long-term consequences. Questions like, do we have access to safe and effective treatment also in future, because sometimes it's quite expensive. Another really major issue are the socio-economic burden. And finally, the emotional factors. Many of the parents feel guilty of transmitting a genetic disease. So this observation, these results were confirmed by the international study, the HERO study, and this was a multi-center international study with the objective to understand the individual and the society burden of patients with severe FMF, MKD and TRAPS during and between flares, but also the impact on the caregivers and families. And it was the same goal to characterize the unmet needs. Almost 70 patients from 10 sites in Europe and the States were included, most of them FMF, but also other severe forms of autoinflammatory disease. And as you can see here, 24 children and adolescents and about 30 adults were participating. Next one. So we collected data during a flare and off flare, and they were focusing on the patient function, the quality of life, and the disease activity. Next one. And these are just a few results of the HERO study. As you can see here, the children told us that it was about 40% that the disease had a major impact on their education. For example, they said they studied fewer subjects and took fewer classes because of their disease. Next one. If we look to the adults, almost 80% told us that their disease had a significant impact on their work achievement. They struggle to keep up with their workload, for example, and they were working fewer hours. Next one. And I think this is the first study, at least, who was looking into the load of the caregivers. And as you can see, 70% of the healthy caregivers told that the disease of their child had an impact on their work performance, and all of the parents and caregivers who were working part-time said it was because of the disease of their child. Next one. So we can summarize, the vast majority of patients and caregivers reported that the autoinflammatory disease interferes with the social activities. The scores for quality of life were consistently lower in comparison to the normative US population, as well as the psychosocial summary score. Next one. So the conclusion was the severe autoinflammatory disease really had broad impact on the lives of patients and their family, and specifically during a flare and therapeutic intervention, but also psychosocial support is needed. Next one. So I was talking a lot about problems and the burden, and the question is now, how can we support really patients and their families to live with this disease? Next one. And one question, it just takes a team. We need experts to control inflammation, but we also need other specialties who really support the families and the patients, that they are really empowered, that they are able to live with their disease, that they are able to take part in the normal daily life. Next one. And for years in our center we are working with this multidisciplinary team, including teachers, psychosocial workers, therapists, nurses, physicians, and also patients' representatives who help us really to focus on the right problems. Next one. One really very important part is the comprehensive psychosocial care, which at least the patients are telling us. So every patient, every family who comes for the first time to our center, they have a psychosocial consultation, and if needed they can have a follow-up. But the goal is for the psychosocial worker really to build up a network of support in the area where the patient and the family are living, and to build up a comprehensive care and support them in their education and workplace. And we also have a program for transition to help the adolescents and young students really to get good care also from adult rheumatologists. Next one. Then we have our patients day, like you have here, and it's a highlight for many of our patients. They come all over the country, we share experience, and I think one of the main feelings they always say, I'm so glad I'm not alone. We can share our experience, we can support each other, and really good friendships developed at these kind of meetings. And it's nice to experience all the doctors and experts also in a more relaxed atmosphere. We have time, we have fun together, and we can answer many of these questions. And the goal is to empower the patients and their families really to live with their disease. Next one. And then as I said, we have the teacher, and they have general information for our families and patients with autoinflammatory disease. They have individualized materials for each of the disease, and if necessary, they go into school and really talk to the classmates, to the teacher, and inform about the disease. Next one. Next one. And then there's the Rare Autoinflammatory European Council. The steering committee is from several patient groups from Europe, but also from healthcare profession, and their idea is really to work that there is more awareness of this rare disease, of this rare autoinflammatory disease, and also to develop more comprehensive care for these patients and their family. Next. This is one of the pictures from our last patient day. We had a photo box so they could make funny photos, and I would like to end next one, with this lady. She was 30 when we were able to treat her with IL-1 blockade. She had a severe form of hyper-IgD. And when we were treating her, she was really able going back to work, and then at the age of 32, she was able to move in her own department, in her own apartment, because since then she couldn't live on her own. She always was reliable on her parents. And then she really sent us this letter telling us, thank you very much, I received a new life. And this is for us very encouraging, and I think it's also encouraging for you who are maybe sometimes really sitting in the middle of a crisis to see that it really can end really very good, and we are happy to support you. Thank you very much for your attention. The pediatrician, they know a lot about this kind of autoinflammatory disease, and it was quite a hard time for the adult rheumatologists to accept that the pediatricians know even more. So we are lucky because we have now a center where we all work together. So if we, for example, diagnose a child and then are suspicious that the parents and the relatives maybe have the same disease, we try to work together. And now, since they are realized, we have really good therapeutic options, the adult rheumatologists are sharing patients with us. So even if a patient comes to them with fever or whatever, high elevated inflammatory parameters, and they don't know what it could be if it's not clear cut, we just sit together. And I think this is the future. We have to sit together. Sometimes we are able to find the genetic cause, quite often we are not. When we need functional tests, but what I have learned, even if we do not find the name yet for this kind of disease, I think it's our obligation really to help the patients and their family, and really to go with them the way until they have the diagnosis and they feel better.
On one of your slides, you mentioned the prevalence of psychological development of psychological problems. The prevalence was much greater for people that had the MD. And I just was curious, you cited a lot of environmental factors, but has there ever been a study about potential genetic factors that, because this is a genetic-based physical condition, that that's also somehow perhaps causing the psychological condition?
The question is if we have any data if the psychosocial problems are also caused by genetics. Actually, I'm not aware of. The only thing what we observe is that patients, if they are not treated, they are more depressed, and maybe it's just because of the inflammation. And depending on the level of inflammation, we got the feeling, they are really, the higher the inflammation, the more depressed and the more fatigue, and it's kind of getting worse and worse. And if we treat them, sometimes it's the total opposite, and I think this has really the major impact. And the genetic is more indirect. If we have a mutation with a lot of inflammation, so there is more risk for these groups than in others. If you have only mild disease, you can more or less live with it. But if you have a severe disease and restricted to many things you would like to do, it's different.
Thank you.